Okay, let's unpack this. Welcome back to the Deep Dive, where we take that dense, mission-critical information you need for your BSN program and really craft it into the most effective study guide we possibly can.
We're here to give you the clarity, the context, and really the clinical why behind all the core facts you absolutely have to master.
Today, we are undertaking a deep dive into, well, one of the most clinically relevant and complex areas of medical surgical nursing.
Oh, absolutely. The management of patients with urinary and renal disorders. This is a topic where, tiny changes in lab values can reflect just enormous systemic failures. Precision is everything here.
And our mission today is really to synthesize the high-yield concepts, those critical benchmarks, and the essential management protocols. And we're pulling them directly from the course material provided for the BSN program, Fall 2025-2026.
If it's in your curriculum, we are going to make sure it sticks.
But before we even get into the content, there's a really crucial professional acknowledgement we have to make.
We really do. We have to extend our sincere thanks to Dr. Abdulkareem Iblasi for preparing this incredibly comprehensive and, frankly, detailed material.
Yeah.
We're using his expert structure as our guiding map for this whole conversation.
And for all of you out there listening, for all you learners, please understand that while this deep dive is designed to be a powerful study shortcut, an overview like this is a supplement. That's all it is.
It's intended to reinforce the learning you get in the classroom. True application and, mastery of this knowledge, it just necessitates attending the full class.
Yes, and engaging actively with Dr. Iblasi, with all your professors and doctors, and participating fully in those vital clinical interactions. This is the foundation. But the house, well, that's built on the clinic.
Absolutely. The material even sets out clear learning outcomes that reflect that holistic approach. Outcome A1, for instance, tasks you with identifying the causes, manifestations, diagnosis, and management of these disorders.
And A2 takes it a step further. It requires you to understand the clinical procedures, the indications, special precautions, contraindications, and the equipment needed for all those diagnostic and therapeutic interventions.
So every concept we expand on today, it all connects back to helping you achieve competence in those specific outcomes.
Right, so diving right into the assessment phase. The sources highlight this really critical challenge that I think distinguishes great nursing care from just adequate care.
And what's that?
The communication barrier surrounding urologic health.
Oh, this is huge. It's often overlooked in, a purely academic setting, but it's massive in practice. Getting a urologic health history requires phenomenal communication skills because patients, they frequently feel intense embarrassment or discomfort.
We're asking deeply personal questions.
Exactly, about their most intimate bodily functions. And that discomfort, what's the clinical consequence?
It leads to incomplete or just inaccurate information. A patient might minimize their symptoms or they skip the details that could be the absolute key to their diagnosis.
Right. They'll say they have some urgency, when in reality, they leak urine every single time they stand up.
So as clinicians, we have to master that non-judgmental language and rigorously avoid medical jargon so the patient feels safe enough to share the whole truth.
That comfort level is step one. It's step one in identifying risk.
And speaking of risk, the list of predispositions for renal and urinary disorders it's extensive. If you're preparing for an exam, this who is vulnerable list is a central memory anchor for you.
These are the conditions that cause that slow chronic damage, or they set up the perfect environment for an acute infection or an obstruction.
So where do we start?
Let's focus on the systemic diseases first, because they often cause damage so insidiously. I mean, everyone knows uncontrolled hypertension and diabetes mellitus are massive drivers of chronic kidney disease.
Right. The constant stress on the renal vasculature is just unrelenting.
But the list goes deeper. You have autoimmune conditions like systemic lupus erythematosus or SLE. So for the learner, why is SLE pose such a high risk for kidney damage?
It's because SLE is a systemic inflammatory disease where the body produces autoantibodies, right?
Exactly. And in the kidney, these antibodies attack the basement membrane of the glomerulus. It causes direct inflammation. We call it lupus nephritis. It's a full-on autoimmune assault on the filtration system itself.
And it's a leading cause of severe chronic renal failure in patients with SLE.
It is. And we also see things like inflammatory bowel diseases like Crohn's disease on this list, along with metabolic disorders like gout and hematologic issues like sickle cell anemia. That's a really wide net.
It is, and the connections are crucial. With gout, what's the mechanism?
High levels of uric acid can precipitate and form stones. Uric acid, nephrolithiasis.
Okay, and sickle cell.
In sickle cell anemia, those sickle-shaped cells can actually obstruct the renal microvasculature. And over time, that leads to ischemia and papillary necrosis. The kidney is just so highly vascular that anything compromising blood flow or introducing damaging substances is a risk.
Okay, let's shift to the historical and infectious risk factors now. This is where you really have to dig deep into a patient's past. We're talking about childhood infections.
Things like strep throat, impetigo, and nephrotic syndrome.
So why are these conditions, which, seemingly resolve, why are they still relevant years or even decades later?
Because they often precede acute glomerulonephritis, AGN, which we'll get to. Strep throat specifically can trigger a post-infectious process. The body creates these immune complexes that then get deposited in the kidney's filtering units, the glomeruli.
So that initial damage, even if it was mild, can predispose the patient to chronic issues or acute nephritis episodes down the line.
Exactly. Now let's pivot to the iatrogenic and physical factors, the things that involve medical intervention or physical changes.
Like instrumentation of the urinary tract, cystoscopy, catheterization.
That's a direct risk pathway. Anytime you breach the sterile urinary tract, even with a sterile catheter, you are creating an entry point for bacteria.
Which is why catheter-associated UTIs, CIUTIs, are such a huge focus in quality care.
Right. And what about something like physical restriction, like immobilization? Why does just being stuck in bed pose a risk to the kidneys?
That's a great question. It's about calcium metabolism.
Tell me more.
When the body isn't bearing weight, calcium actually leaches from the bones. This increases both serum and urinary calcium levels, making the urine supersaturated.
Which sets the stage for the formation of calculi, stones. Prolonged immobilization is a known precursor to urolithiasis.
And finally, there's that environmental component, occupational exposure to chemicals.
Things like plastics, pitch, tar, and rubber. These are classic nephrotoxins. They can cause chemical injury to the renal tubules over a long period of time.
So let's tie this all together. If you have a patient with a history of SLE, what are you worried about?
Chronic renal failure, CKD.
If they have recent instrumentation or they're immobilized?
Infection and obstruction. And if we see an obstruction, whether it's from a tumor, BPH, or stones, what happens immediately downstream from that blockage?
Obstruction leads to incomplete emptying of the bladder.
Which causes stasis, frequency, urgency, and eventually.
Eventually, oliguria, which is decreased output, or even anuria absent output, if the blockage is bilateral or really severe. You have to know these cause and effect pairs. They're the clinical pivot points.
Okay, we've assessed the risks. Now let's shift into the critical numbers and tests you have to master. We're moving from general assessment into the hard data that confirms renal dysfunction.
And we start with the most essential screening tool, urinalysis and culture.
For the exam, you need the benchmarks. Start with specific gravity. The normal range is 1.005 to 1.020. This just measures the density of the urine relative to water. It tells us how well the kidney can concentrate or dilute urine.
But let's not just memorize that range. Let's talk clinical interpretation. If a patient comes in dehydrated, you'd expect that specific gravity to be high, right? Maybe 1.028.
Absolutely.
But what if a patient is clearly dehydrated, yet their specific gravity is fixed at 1.010?
That fixed specific gravity is a huge red flag. 1.010 is the specific gravity of plasma filtrate. It means the kidney is neither concentrating nor diluting the urine. It's basically just filtering plasma and letting it flow right out.
Which often indicates what?
Severe renal tubular damage or disease. That ability to interpret the meaning of the number, well, that's what separates the memorizer from the clinician.
And the most accurate measure of that concentrating ability is osmolality. The normal range is 500 to 1200 millosm/kL. And the sources highlight that changes in osmolality are often seen early in disease processes.
Exactly, because the kidney's ability to respond to antidiuretic hormone, or ADH, and adjust water reabsorption gets compromised very early on. Osmolality helps us detect that functional impairment before the major filtration markers like creatinine start to climb dramatically.
Okay, so when we're looking at the microscopic exam, we're searching for obvious pathology. Things like protein, RBCs, ketones, glycosuria.
And of course, bacteria. For infection markers, what are the two crucial chemical indicators we're looking for on that dipstick?
Leukocyte esterase and nitrites.
Right. Leukocyte esterase is an enzyme released by white blood cells in response to infection, and the nitrites.
The presence of nitrites indicates that certain common bacteria, like E. coli, have converted the nitrates that are naturally present in urine into nitrates. Both of those are a strong signal of an active UTI.
Now let's clarify some confusing terminology around protein. The material mentions albuminuria, referring to albumin in the urine that is not measurable by a dipstick. This is a crucial concept for early detection.
Yes, clinically, this is often called microalbuminuria. The standard dipstick only detects gross proteinuria.
But microalbuminuria is the presence of very small trace amounts of albumin that indicate damage to the glomerular filtration barrier. This often happens before the serum creatinine even starts rising.
It's the single most important early marker for diabetic nephropathy, right?
It is. It's a key indicator that aggressive management of blood sugar and blood pressure has to start immediately to prevent progression to CKD. That context is vital.
Okay, now let's move to the non-negotiable big three indicators of overall renal function. Hit us with the essential numbers.
First, serum creatinine, normal range, 0.6 to 1.2 mg/dL. This is the measure of effectiveness. Creatinine is a byproduct of muscle metabolism, and it's filtered almost entirely by the glomerulus.
So a rise in creatinine almost always signifies a decreased GFR.
Almost always. Second is urea nitrogen, or BUN. Normal range is 7 to 18 mg/dL. It's a byproduct of protein metabolism. Now, the critique here is that BUN is less specific than creatinine.
So if we see a high BUN, what non-renal variables do we need to rule out before we start panicking?
Excellent question, because a high BUN alone can absolutely mislead you. If a patient is severely dehydrated, they can have a high BUN because the body is reabsorbing more water and, with it, more urea.
Or a high protein diet or a GI bleed.
Right. That massive protein load being metabolized will also spike the BUN. So we always look at the BUN creatinine ratio. If both are elevated, it's likely renal. If the BUN is disproportionately high, we start looking for dehydration or other volume issues.
Which brings us to the gold standard, creatinine clearance. This calculation directly reflects the glomerular filtration rate, or GFR.
GFR is the central concept in renal physiology. We define GFR as the volume of fluid filtered from the renal glomerular capillaries into Bowman's capsule per unit of time.
It's expressed in ml/minute, and the normal benchmark is generally 125 millivol/minute.
And when that number starts dropping, say, below 60 millil/minute, that defines the onset of chronic kidney disease.
Okay, so we have the chemical evidence now. How do we confirm the location, the structure, and look for physical obstruction? That's where imaging comes in.
Let's run through the indications for the common studies. We start simple with a KUB, a basic X-ray of the kidney, ureters, and bladder. Its primary use is checking size, shape, position, and detecting radiopaque abnormalities.
Like most kidney stones.
Like most calculi, or looking for signs of hydronephrosis.
Then you have the versatile ultrasonography. It's non-invasive, easy to use at the bedside.
Ultrasound is perfect for identifying fluid accumulation, masses, congenital malformations, size changes, and confirming hydronephrosis, that distension of the renal pelvis because of an obstruction. It gives you a real-time functional assessment.
For the kind of detail you need in soft tissue, or for complex masses, trauma, metastatic disease, we use CT and MRI.
Right. Those studies give us the excellent cross-sectional views we need for precise localization.
And finally, cystography. This involves inserting contrast directly into the bladder to visualize it.
And this specific test is used to evaluate vesicoreteral reflux, the backward flow of urine from the bladder up into the ureters. And it's essential for assessing bladder injury after trauma.
Now, a critical reminder for the learner, and this ties back to that outcome A2. Knowledge of the test is only half the battle. The source material specifically instructs you to review page 1269, chapter 43. Why is that chapter on nursing care so vital?
Because it covers the pre- and post-test preparation and precautions.
Yeah.
For any IV study using contrast, like a CT with contrast, you have to ensure the patient has adequate renal function.
Checking that serum creatinine first.
You have to before giving that nephrotoxic dye. And you have to monitor for delayed allergic reactions. If the patient's undergoing an invasive procedure like a cystoscopy, you're monitoring for post-procedure bleeding, infection, and maintaining strict bed rest if required. Mastering the procedure care is a requirement for safe practice.
Now we move to UTIs, which can range from a simple inconvenience to life-threatening sepsis. For the exam, the learner must be able to instantly categorize the infection by location and complexity.
Let's nail the location first. A lower UTI is simpler. It involves the bladder and the structures below it. So we're talking about cystitis, which is the bladder, prostatitis, and urethritis. The symptoms are all localized to the voiding process.
An upper UTI, on the other hand, is the danger zone. This involves the kidneys and the ureters.
And the complication here is acute or chronic pyelonephritis, a renal abscess, or interstitial nephritis. When that infection hits the kidney, it becomes a systemic problem.
Then there's the complexity scale.
Right. Uncomplicated UTIs are community acquired. They're common in young women, and they occur in a structurally normal urinary tract. They respond quickly to standard oral antibiotics.
In contrast, complicated UTIs are the ones that raise our alarm bells. They're frequently nosocomial, so hospital-acquired.
Often related to catheterization, or they occur in patients whose anatomy or physiology is already compromised. Think diabetes, pregnancy, known obstructions, immunosuppression. These are the patients who progress to urosepsis.
And speaking of alarm bells, let's talk about the silent killer, asymptomatic bacteriuria. The material notes that about half of patients with bacteriuria have no symptoms at all. Why is this so critical, especially in that complicated patient population?
Because in a young, healthy patient, their immune system might fight it off, or maybe they just get lucky. But in a frail, hospitalized, or catheterized patient, especially someone elderly or diabetic, that silence means the infection can replicate completely unchecked in the bladder.
And then it can suddenly ascend to the kidney, causing pyelonephritis and leading directly to septic shock urosepsis without any of the typical warning signs like dysuria. We just can't rely on symptoms alone.
So, if the patient is symptomatic, the clinical presentation helps us differentiate. For the typical uncomplicated lower UTI cystitis, we see dysuria, the pain or burning frequency, urgency, nocturia, and maybe hematuria.
But when that infection moves up to the kidney, to pyelonephritis, the symptoms become systemic. High fever, chills, nausea and vomiting, generalized malaise. And the physical assessment key identifier is just unmistakable.
Yes. The definitive physical finding for pyelonephritis is intense pain and tenderness when you percuss at the costovertebral angles, CVA tenderness.
And that maneuver is performed by just tapping gently over the kidney area on the back.
Right. And sharp pain confirms inflammation in the renal capsule. It differentiates upper tract involvement from simple cystitis. That is a must-know clinical sign for any exam.
Okay, let's briefly touch on the pathophysiology hook. The mechanism is almost always ascending.
Fecal organisms, usually E. coli, ascend from the perineum, they adhere to the urethra, and colonize the urinary tract epithelium. They manage to evade the natural washing out mechanisms avoiding.
So for management, specifically for acute pyelonephritis, our first diagnostic steps are structural. An ultrasound or a CT scan. Why start there?
Because an obstruction changes the management completely. If there's a stone or a structural blockage, antibiotics alone aren't going to clear the infection. The blockage itself must be addressed.
And we also rely heavily on urine culture and sensitivity.
To ensure we choose the right targeted antimicrobial therapy, medical management dictates that most uncomplicated acute pyelonephritis cases are managed as an outpatient with oral antibiotics.
However, hospitalization is mandatory if the patient is what?
Dehydrated, vomiting, pregnant, or showing any early signs of sepsis.
And if they're hospitalized, they get IV or parenteral therapy for 2 to 3 days until they're clinically improved and afebrile. Then they transition to a standard 14-day course of oral antibiotics.
Usually something like TMP, SMZ, ciprofloxacin, or gentamicin.
And the learner has to remember the relapse protocol. If that infection is stubborn or it becomes chronic, the antibiotic course may be significantly extended.
Sometimes up to 6 weeks, to ensure complete eradication and prevent chronic damage to the kidney structure.
And here is the high-yield compliance and follow-up fact that Dr. Iblasi's material emphasizes. A follow-up urine culture must be performed 2 weeks after the completion of the antibiotic therapy.
It's the only way to officially document that the infection has been cleared. And that is absolutely essential to prevent chronic pyelonephritis and scarring.
Okay, let's move to the inflammatory disorders, starting with acute glomerulonephritis, or AGN, inflammation of the glomerular capillaries. And while it's often a disease of children older than 2, it can hit any age group.
This is where you need that classic presentation to just jump out at you instantly. What's the clinical triad that identifies AGN?
First and foremost, hematuria. This is the primary feature. It can be microscopic, but often it's macroscopic.
Yeah.
It's visible.
And the classic high-yield exam description is cola-colored urine. This dark, smoky color is due to the presence of protein casts and high concentrations of RBCs, and specifically RBC casts, which are definitive evidence of active injury to the glomerulus itself.
Second is proteinuria, specifically albumin. This happens because the inflammation damages that tight filtration barrier, allowing large molecules like protein to leak into the filtrate.
And third, edema and hypertension. It's noted in 3/4 of patients. The damaged glomeruli retain salt and water, which leads to circulatory volume expansion.
And that manifests as swelling, usually periorbital and facial swelling at first, and high blood pressure.
Right. And the pathophysiology timeline is the connecting bridge here. The onset of symptoms is abrupt, but it's preceded by a latent period, on average, about 10 days after an antecedent infection, most commonly streptococcal pharyngitis, strep throat.
That history is the clinical clue that unlocks the diagnosis. The body launches an immune response against the strep bacteria, but those antigen-antibody complexes get trapped and deposited in the tiny capillaries of the kidney.
Causing an inflammatory storm.
That classic triad is pretty clear. But let's talk about the nightmare scenario for nurses. The atypical symptoms in the elderly. The older patient often doesn't follow the textbook.
Not at all. They rarely present with the classic edema and flank pain. Instead, their presentation often mimics severe circulatory overload.
So you see dyspnea, engorged jugular neck veins, JVD, signs of pulmonary edema. The fluid retention is interpreted as heart failure.
Or still, they can present with atypical neurologic symptoms, confusion, somnolence, even seizures. And if the clinician doesn't suspect renal involvement, they might be treated for a primary neurologic disorder or a stroke, losing precious time.
And the complications here demand immediate recognition. Hypertensive encephalopathy is a medical emergency. It's caused by severe, uncontrolled hypertension that leads to cerebral edema.
An immediate controlled reduction of blood pressure is vital. The sources also list another emergency, rapidly progressive glomerulonephritis, or RPGN. This is a terrifying condition where function just crashes fast.
It leads to end-stage renal disease, ESRD, in a matter of weeks or months without aggressive treatment, often involving high-dose immunosuppression and plasmapheresis.
So management goals are preservation and symptom control. If residual strep is suspected, penicillin is the agent of choice. We use immunosuppressants like corticosteroids for the severe, rapid cases.
And diet is critical. If the patient develops signs of renal insufficiency, meaning elevated BUN and creatinine, we implement protein restriction.
But for all patients with edema or hypertension, sodium restriction is non-negotiable to manage their volume status.
From a nursing care standpoint, fluid management has to be meticulous. We measure INO, and fluids are calculated based on output, plus an estimate for insensible loss.
The 500 to 1,000 milliliter lost through skin and lungs daily. And to ensure the patient has energy but doesn't catabolize their body protein, we provide liberal carbohydrates in the diet.
We address the culmination of failure now, renal failure. This is when the kidneys can't remove metabolic wastes or perform their regulatory functions,
leading to the accumulation of waste products, azotemia or uremia, and severe systemic disruption.
We have to be clear on the time frame difference. Acute kidney injury, or AKI, is sudden. A complete or near-complete loss of function, a decreased GFR, over hours to days.
And it is frequently reversible if it's caught and treated promptly. The hallmark manifestation is oliguria, defined as less than 400 milliliter a day of urine output. Anuria, which is less than 50 milliliter a day, is less common but much more severe.
The defining lab sign is a rapidly rising serum creatinine and BUN azotemia.
And clinically, these patients look gravely ill. Beyond the obvious lethargy and nausea, look for the subtle signs. The skin and mucous membranes are dry. A key finding listed in the material is uremic fetor,
The odor of urine on the breath,
caused by the buildup of waste products. You'll also see CNS signs like drowsiness, muscle twitching, and seizures as those uremic toxins build up and irritate the nervous system.
The diagnostic labs reveal a low urine-specific gravity, often fixed at 1.01 or less, like we talked about earlier. But the most immediate danger is the electrolyte imbalance,
particularly hyperkalemia and severe metabolic acidosis.
So let's focus on management for AKI, because this is where immediate nursing intervention saves lives. The objectives are to restore chemical balance and prevent catastrophic complications until the kidney tissue can recover.
Fluid balance is paramount. We have to monitor daily body weight and central venous pressure, or CVP, frequently. Why CVP monitoring?
Because in AKI, you're walking this tightrope between dehydration, which perpetuates the injury, and fluid overload, which leads to pulmonary edema and heart failure.
CVP gives us a direct, real-time measure of fluid status and preload. We have to be hyper-vigilant for signs of fluid excess. Crackles in the lungs, distended neck veins, generalized edema.
Okay, now for the crucial pharmacology. The immediate life-threatening complication is hyperkalemia. It causes peaked T waves and ventricular dysrhythmias. What's the standard pharmacologic intervention listed in the source material?
The standard intervention is cation exchange resins, specifically sodium polystyrene sulfonate, better known as Kayexalate. It's given orally or via a retention enema.
Think of Kayexalate as a tiny chemical Pac-Man moving through the colon.
That's a great analogy. How does that Pac-Man work?
Kayexalate works by exchanging a sodium ion for a potassium ion in the intestinal tract. It binds the potassium, and because the resin isn't absorbed, the potassium is then excreted through the stool.
And to ensure rapid elimination and prevent it from binding up in the gut, it's almost always administered in combination with sorbitol, which acts as a laxative.
It induces diarrhea to ensure that bound potassium is eliminated quickly. So if the patient have a paralytic ileus or their bowels just aren't moving, is Kayexalate safe?
Absolutely not. Giving Kayexalate to a patient with a non-functioning gut or ileus is contraindicated because the resin can accumulate and cause bowel necrosis. That is a critical nursing precaution.
Other interventions include using diuretic agents like mannitol or furosemide to try and kickstart diuresis and flush the system if their volume status allows for it.
And for severe acidosis, we need rapid intervention, either with sodium bicarbonate therapy or immediate dialysis. When serum phosphate is elevated, we use phosphate binding agents like aluminum hydroxide
to bind the dietary phosphorus in the GI tract before it can be absorbed.
Right. And interestingly, the material mentions experimental agents like low-dose dopamine to dilate renal arteries and atrial natriuretic peptide, or ANP, to potentially improve function. It just shows the ongoing search for ways to support the failing kidney.
Now, moving to chronic kidney disease, or CKD-ESRD. This is the irreversible deterioration. The GFR has crashed below 15 millil/minute. The body has completely lost its homeostatic balance.
The management goal shifts from restoration to maintenance. We're trying to maintain homeostasis for as long as possible, often involving renal replacement therapy like dialysis or transplant.
Specific treatments focus on managing the systemic fallout. We use aluminum-based antacids to combat hyperphosphatemia and the resulting hypocalcemia. And critically, anemia is managed with synthetic erythropoietin.
Erythropoietin. Abanin, because the diseased kidney no longer produces enough of the hormone to stimulate red blood cell production.
And finally, we have to memorize the key nursing diagnoses associated with CKD-ESRD, as these define the care plan and demonstrate an understanding of the patient's comprehensive needs.
The list really summarizes the entire clinical picture. Excess fluid volume.
Due to decreased output.
Imbalanced nutrition. Less than body requirements.
From the anorexia, nausea, and all the dietary restrictions.
Deficient knowledge because of the sheer volume of self-care required. Activity intolerance from the anemia and fatigue. And low self-esteem related to role changes, dependency, and body image issues.
If you can understand those 5 diagnoses, you understand the devastating impact of chronic kidney failure on a patient's entire life.
Let's transition now to a highly prevalent and extremely painful clinical problem. Urolithiasis, kidney stones.
The pathophysiology of stone formation is really rooted in simple chemistry and physics. Stones form when the urinary concentration of specific elements, calcium oxalate, calcium phosphate, uric acid increases,
leading to supersaturation, which means there is more solute dissolved than the urine can actually hold.
But supersaturation isn't the only factor, is it? There's also a protective element that can fail.
Exactly. Stones also form when there's a deficiency of natural crystallization inhibitors in the urine, things like citrate, magnesium, nephrocalcin. If those protective substances are lacking, crystals can aggregate and grow much more easily.
And the key contributing factor that underlies almost all stone types is a simple lack of fluid volume, dehydration.
The diagnostic workup for stones is often more complex than just an X-ray. While a KUB or an ultrasound can locate the stone and any obstruction, the absolute essential diagnostic component listed in the material is the 24-hour urine test.
This test is the key to prevention. It doesn't just measure total volume. It measures the excretion of calcium, uric acid, creatinine, sodium, and most importantly, urine pH.
And the results tell us what kind of stone the patient is forming, which then dictates the specific dietary and pharmacologic prevention strategy.
Let's break down the major stone types and how that 24-hour test guides treatment. The majority of stones are calcium oxalate or calcium phosphate stones. What does the urine pH typically look like in these patients?
Calcium stones typically form in alkaline urine, so a high pH, or in patients with hypercalciuria. Treatment focuses on reducing that supersaturation. Increasing fluid intake is essential, and sometimes thiazide diuretics are used.
Which seems ironic.
It does, but they work because they actually decrease calcium excretion in the urine. We also need to measure the sodium in the 24-hour test because a high sodium intake forces more calcium excretion.
Then you have uric acid stones. How are those diagnosed and prevented?
Uric acid stones form when there's hyperuricasuria, and they classically precipitate in acidic urine, so a low pH. The 24-hour test will show high uric acid levels.
So prevention is twofold.
Right. We use drugs like allopurinol to decrease uric acid production, and we prescribe medications like potassium citrate to alkalinize the urine, raising the pH to help dissolve the stones.
We also have struvite stones and cystine stones. Struvite stones are sometimes called infection stones.
They're the consequence of persistent UTIs caused by urea-splitting bacteria like Proteus, which raise the pH and facilitate stone formation. They can grow very large and require surgical removal and aggressive antibiotic management.
And cystine stones.
Thankfully rare. They're caused by a genetic defect in renal absorption and require very high fluid intake and specific medications to increase their solubility.
So management goals are pretty clear. Eradicate the stone, relieve any obstruction or infection, and determine the stone type to prevent recurrence.
Acute pain relief is the first step. Renal colic is legendary for its severity. We use opioid analgesics and NSAIDs, complemented by non-pharmacologic measures like moist heat to the flank areas.
But the core therapy, unless there's an obstruction or fluid restrictions, remains what?
Pushing fluids.
And the surgical options are increasingly less invasive. We have ureteroscopy to retrieve or break up lower stones, and extracorporeal shockwave lithotripsy, or ESWL.
ESWL is amazing. It uses non-invasive shockwaves generated outside the body that are targeted to break the stone into sand-like fragments, allowing the patient to just pass them naturally.
Which requires careful nursing monitoring for bruising and ensuring adequate fluid intake post-procedure to facilitate passage.
And the critical nursing diagnoses for urolithiasis focus on acute care and prevention. Acute pain related to the inflammation and obstruction, and deficient knowledge regarding the prevention of recurrence. Mastering that prevention education based on the 24-hour urine results is paramount for patient success.
So what does this all mean for the BSN learner facing an exam, and more importantly, a patient? We've covered concepts that are really clinical pivot points.
If you were compiling the ultimate memory checklist of differentiators, what stands out?
I think we have to reiterate the quick identifiers. You must know that CVA tenderness equals an upper UTI, pyelonephritis. You must know that the abrupt presentation of cola-colored urine points directly to AGN.
And you must know that an elevated BUN in the presence of a normal creatinine suggests volume depletion or a GI bleed, not just primary renal failure.
And remember the complexity of AKI management pharmacology, knowing that chiexolate is the go-to intervention for life-threatening hyperkalemia.
And the necessary partnership with sorbitol to ensure that potassium is excreted while you're simultaneously monitoring for severe GI complications like ileus.
We want to close by circling back to our opening, thanking Dr. Abdulkareem Iblasi once more for compiling the structure that allowed for this in-depth analysis. This detailed overview is a powerful foundation for your studies.
But we have to stress the professional expectation one final time. True mastery and the ability to apply this knowledge safely in clinical practice requires continued engagement. You must be attending those lectures, engaging with your doctors, questioning the processes.
And developing your critical thinking skills as part of your BSN program. That is how you move from just knowing the facts to becoming a safe, competent, and insightful clinician.
To leave you with a final provocative thought, consider the sheer, profound, systemic reach of renal failure. The simple inability to excrete waste cascades far beyond the urinary tract.
It causes CNS signs like seizures and confusion, severe cardiovascular volume overload, endocrine disruption. Think Ibogen for anemia and bone pathology.
Mastering the intricacies of the renal and urinary system is critical because the kidney acts as the body's ultimate homeostatic regulator. When it fails, everything fails. The knowledge we've covered today dictates promptness in intervention, and that precision saves lives.
That's all the time we have for this deep dive. Study smart, apply harder, and we'll catch you on the next deep dive.